Nice. Let's crack on then. So, welcome to BiteMedicine's 95th webinar. We are rapidly approaching our 100th webinar. For those of you who don't know me, my name is Azim. I'm one of the co-founders of BiteMedicine. I'm a doctor in central London. And we founded the BiteMedicine probably around a year and a half ago. So for everyone who is new here, welcome. For everyone who has been around since the beginning, welcome back. The growth that we have had has been absolutely phenomenal, and we're so grateful for all of your support as always. We have some incredible new things planned. I feel like I haven't done a webinar in so long, mainly, and like my hair is so long because I've been so busy. We've got lots of new collaborations with institutions, universities, new community bits and pieces coming out, all sorts of things, prescribing, OSCEs, lots of cool stuff over the upcoming few months. So watch this space, and hopefully we can create lots of new content for all of you. And yeah, I hope you're all keeping well and staying safe, most of all. But yeah, without further ado, let's crack on. So we're continuing our infectious diseases series. You did part one with Schwabe, I think it was last week, and this is a continuation of that. So infectious diseases that we're going to be covering today are neurological. So infectious diseases of the nervous system. And we're going to be covering a few really big ones and then a couple of smaller ones, which frequently come up in exams, but less frequently seen in clinical practice. So aims and objectives, as always, our target audience is our medical students in their clinical years and physician associates, aiming for around 60 minutes. As we said, we're going to be covering infections of the nervous system today, so neurological infections. We'll be focusing mainly on kind of organisms, but then we're linking that into clinical features, how we investigate, how we manage. And as always, interactive questions with the Mentimeter. Pop any questions either in the Q&A or the chat, and I will get down and get them answered as soon as I can. Apologies, the slides have not been uploaded yet. As soon as this webinar is over, I will upload the slides. I literally just got back from work, so apologies for that. They'll be uploaded straight away when I close the meeting, so my apologies. Okay, so let's crack on. Obviously, you've all kind of seen, hopefully, our question bank online textbook, all based on most recent UK NICE guidelines. So do check those out if you can, and obviously use our promo code, well, my promo code, Azim 2021, if you'd like an additional 20% off your either monthly or annual subscription. So take advantage of that if you would like. All right. So basic point to start off with, as you know, if you've been around for a while, I love to start off with kind of basic anatomy, pathophysiology. This is just a very basic overview of your nervous system. So I just want you to try and get in that mindset of what we're talking about today. So particularly focusing mainly on infectious diseases of our central nervous system. So that's essentially your brain and your spinal cord. And then as we get near the end, we'll touch on some other more niche bits and pieces as well. So as we always do, we're going to run through a bunch of cases, and these will be highlighting these key conditions that we'll be talking about. So case-based discussion number one. We have a 19-year-old female law student studying in London who reports to her GP that she's been feeling generally unwell. She describes a vague, generalized headache and has vomited twice. When the GP turns the light on, the patient covers her head with her coat. So hopefully you've already got some thoughts in terms of differential diagnoses. This is not some really rare, uncharacteristic history. This is a very characteristic history of the underlying diagnosis. So I'm not playing any tricks on anyone. What about these observations, though? Pop them in the chat. What do we think about those obs? Happy, unhappy, and what is abnormal here? Unhappy, yeah, agreed, AP. Yeah, so tachycardic. So the tachycardia and the temperature are certainly the two big things here that I'm concerned about as well. So I would agree. So based on what we just said there, what is the most likely causative organism? As you can see, we've gone one step further, not just asking you the diagnosis, we're thinking what's the most likely causative organism or pathogen. Can everyone see Menti now, I hope? So if you can go to menti.com and type the code there at the top, 40653690. Hopefully you should all be able to see that and getting some answers through now. Give you all a moment to get on there. Hopefully you can see Mentimeter. Good, so we're getting some answers now. I'll give you a few moments to answer this one. So based on that history, based on those observations, what is the most likely causative pathogen or organism? Okay, let's see what you think. Okay, nice. So you said most of you, majority of you has said strep pneumoniae. And you would be, where do we go? Oopsie daisy. And you would be spot on. Out of the options available there, the most likely causative pathogen is strep pneumonia, I would agree. And the reason for that is listed here. So the two most common causes of meningitis, which hopefully you got from the history in this case, are Neisseria meningitidis and Streptococcus pneumoniae. In the UK, those are the two most common causes of bacterial meningitis. These other options, they can cause meningitis. So for example, listeria there is a really important cause, as well as group B strep, tuberculosis, and E. coli. So they're all they all can cause meningitis, but here the most likely cause is strep pneumoniae, essentially based on our epidemiological data that we have. The next question is, I guess, why do we think this is meningitis? Well, students, classically, you head off to university, freshers, and in those first initial periods at universities, that's the classic exam question description of someone who develops meningitis. They're interacting with new people, surrounded by new people, often in quite close quarters. This actual history then, we've got the vague generalized headache with vomiting is very characteristic of meningitis. And then when the GP turns the light on, the patient covers her head with her coat, which is photophobia. So we'd obviously not necessarily expect, but we may see other symptoms such as neck stiffness, and some might expect also, this purpuric rash if we're thinking about Neisseria meningitidis or meningococcal meningitis. But remember that rash, that purplish, non-blanching rash everyone talks about, that is specific to Neisseria meningitidis or meningococcal meningitis. And then obviously the fever and the tachycardia would be expected in any patient with a nasty infection on board. All right, so let's give you a little bit of an intro to meningitis. So meningitis, as I'm sure you know already, is the inflammation of the meninges due to infective or non-infective causes. So there are some non-infective causes of meningitis. It's slightly beyond the scope of today's webinar. So obviously we're going to be focusing on the infective causes of meningitis, so bacterial, viral, fungal. So acute bacterial meningitis is one of the top 10 causes of infection-related deaths around the world. So the burden of this condition is significant globally. And strep pneumoniae and Neisseria, as we talked about, are the most common bacterial causes. And when we're thinking about viral causes, enteroviruses are the most common ones and the main ones that we need to be thinking about. In terms of epidemiologically, NICE recently stated that in terms of in the UK anyway, it has an incidence of 5 per 100,000 in the population. And bacterial meningitis has a significantly higher mortality in patients than viral meningitis, as you can see by these figures, really significantly higher. Bacterial meningitis is really the one that we worry about, but of course, all causes of meningitis must be considered as very serious, particularly due to their associated complications. So we've talked a little bit broadly about meningitis. Here's a little bit of basic anatomy for you. I'm sure you all remember your meninges, so these membranous coverings of the brain and the spinal cord, and the three layers of your meninges that you can see there. DAP, so dura, arachnoid, pia, working from outside to in. And these get infected and inflamed, and that's all meningitis is, inflammation of those layers. Let's now think about some risk factors for these processes to occur. So age, so extremes of age, so very young, very old, are at increased risk of meningitis. If you're immunocompromised, so I'm sure we all know numerous causes of patients being immunocompromised, so whether that's conditions like HIV or AIDS, whether you're on medications such as chemotherapy, just simply conditions like poorly controlled diabetes, increase your risk if you're on steroids. Lots of things can cause you to be less immunocompetent than you should, and this increases your risk of meningitis as well. If you're non-immunized, so we have an immunization regime against against meningitis, and we'll touch on that in a moment as well. Smoking is a risk factor, and crowded environment, which obviously partially contributes to that story of students starting university and then contracting meningitis. Good, so hopefully nice and straightforward so far. As I said, any questions, pop them in the chat or in the Q&A. All right, so now let's go into a little bit more depth. So we're going to split things up into bacterial, viral, fungal, just broadly speaking here. So bacterial, as we said, is the one that we mainly worry about because of that really high mortality rate. It is less common than viral, but as I said, higher mortality makes it more kind of in the forefront of our minds when we're thinking about meningitis. It can affect anyone of any age, but particularly those extremes of age are the patients that we worry about the most. And we'll touch on in a bit more depth on some of those organisms as well. We then have to think about viral meningitis. I have a few friends of mine who actually developed viral meningitis, and it was, thankfully quite an indolent, well, not indolent, but I'd say it was relatively self-limiting in and of itself. They weren't floridly septic. They weren't extremely unwell. They were definitely ill, and it's definitely a condition we need to worry about and treat. But on the whole, those massive complications and the really septic, unwell patients are what you would expect in bacterial meningitis. In terms of organisms or pathogens kind of related to viral meningitis, as we said, the most common are your enteroviruses, so your Coxsackies and echoviruses, for example. Herpes simplex virus is really important as well. So HSV1 or herpes simplex virus 1 is the most common cause of viral encephalitis in the West, but HSV2 is more common than HSV1 when it comes to viral meningitis. So HSV1, we're thinking about much more about encephalitis, whereas HSV2, we usually think about viral meningitis. But they both can cause both meningitis and encephalitis. And we'll touch on encephalitis shortly as well. And then varicella zoster is another condition we need to think about when we think about viral meningitis. Fungal meningitis, once again, being immunocompromised particularly is a really big risk factor for fungal meningitis. And there are a couple of organisms there, so your Cryptococcus and your Candida as well. So we also need to think about age, and this is not just important for exams because it always comes up, but important for our antibiotic treatment of bacterial meningitis. So the big one for really young children and neonates particularly is going to be something called Group B Streptococcus. And I'm going to touch on most of these bacteria in a moment. That's a really big one. But obviously we've got these other ones here as well. And when we're thinking slightly older children and we're thinking adults, then these two conditions crop up once again. These two bacteria crop up once again. Even strep pneumoniae, Neisseria are really big ones here in that middle age range of kind of 3 months all the way up to 60 years old. And Haemophilus as well. crops up there. And then our elderly patients, once again, we've still got strep pneumonia, we've still got Neisseria, but then listeria crops up. So listeria is a bacteria that's usually caught from eating food that contains, obviously, the listeria bacteria, and that's found in lots of types of food, but particularly kind of unpasteurized milks and cheeses and various dairy products. So that's where the listeria crops up. And you can see here again, listeria in neonates and kind of really young children, and then also in the very old. So listeria, particularly when we're thinking about bacterial meningitis, affect those extremes of age. Nice. So hopefully that's a nice overview in terms of bacteria, but let's go into a little bit more depth about those bacteria now. So let's start off with Neisseria meningitis. So this is your classic cause of what we call meningococcal meningitis, and that describes that non-blanching purpuric rash. That's what is seen is in meningococcal meningitis. So this is a gram-negative diplococcus. People can just carry this and not necessarily have, florid or really severe symptoms with it. And it colonizes your nasopharynx, and as we said, asymptomatic carriers. It's spread via this droplet spread of your respiratory secretions. Now, thankfully, we do have vaccinations against this. So we have Men-B, Men-C vaccines, and if I focus now here on Men-ACWY, this protects against 4 strains of the meningococcal bacteria, A, C, W, and Y. And therefore, this was only introduced in not that recently, but in recent years. And basically then what the guidelines now say that freshest students going to university for the first time should make sure that they have had this Men-ACWY vaccine to prevent meningitis, to prevent more severe disease and septicemia, which can obviously be fatal. And it's also routinely now offered to teenagers in school years 9 and 10. And obviously this is all talking about the UK. So there are programs in place to prevent really bad meningococcal meningitis and to prevent you from catching it in the first place. Mortality, 10% with it. So have that in your mind, particularly that mortality rate, because you may be surprised when I go on to the next slide and you look at the mortality rate with strep pneumonia meningitis or pneumococcal meningitis. I think we all think about meningococcal meningitis, but actually the mortality rate is significantly higher with pneumococcal meningitis. So strep pneumoniae is a gram-positive cocci that is responsible, obviously, for the majority of your community-acquired pneumonias, but can also cause meningitis. It has, as we said, higher mortality rate and obviously poorer outcomes. And there are vaccinations available. So we're thinking particularly about the pneumococcal conjugate vaccine, or PCV. Is given routinely, according to NHS, to babies, adults aged over 65, and also those with numerous kind of significant comorbidities like serious heart or kidney conditions as well. So that's a little bit about pneumococcal meningitis. So we touched on group B strep, and this is our last big bacteria that we're going to be focusing on here. So group B streptococcus, or Streptococcus agalactiae, is the most common cause of neonatal meningitis, but also pneumonia and sepsis in general. Now, GBS, or group B streptococci, these are found in the gut, kind of the normal bowel flora of 20 to 40% of adults, just physiologically. And those who are colonized with it are known as carriers. However, in babies, when babies are born, and if this bacteria has colonized the vagina, then during that vaginal delivery, or during that delivery, this bacteria can be transmitted to the baby, and they can develop all of these complications that we're talking about. So we don't have routine screening for group B streptococcus, but we will give IV antibiotics protecting women against group B streptococcus, particularly if they have had a previous baby with early or late onset group B streptococcus. So if they've had a previous pregnancy and a baby has had the condition or had the bacteria on board and been symptomatic, then we're going to give that woman intravenous antibiotics during subsequent pregnancy. But as I said, not routinely screened for. Risk factors for it: prolonged membrane rupture and low birth weight. There are a couple for you there. Those are three big bacteria that we need to think about when we're thinking about bacterial meningitis. I'm going to give you another case now. So a 22-year-old presents to the emergency department feeling generally unwell, is wearing sunglasses, complains of a stiff neck with a pounding headache, and has vomited twice. You see him in A&E, and you decide to do some funky tests, one of which you decide to do is something called assessing for the Brzezinski sign, and it's positive, and there is observations. Now, the question here is, which of the following most accurately describes a positive Brzezinski sign? This is not something I routinely test for when I see patients in A&E with suspected meningitis, but it comes up in exams all the time. And it's just one of those eponymous signs which you need to know to some degree. Which of the following most accurately describes this sign? And really, this is most of what you need to know about Brzezinski sign. Okay, let's see what, where's my mouse? There it is. See what people think. Oh, a big split there, as I expected. There we go. So that is the technical definition of a positive Brzezinski sign. It is not specific to meningitis. I do not want you necessarily going around and doing this test on everyone that you see. It is more particularly from an academic point of view. So Brzezinski sign is exactly that, and I'll show you a picture of it. It's passive flexion of the neck causes flexion of the hips and knees. When I say passive flexion of the neck, I simply mean you as the doctor or the PA, passively flexing the patient's neck for them, and that will cause flexion of the hips and the knees. As I said, can also be seen in other conditions like subarachnoid hemorrhage. And this occurs due to irritation of your meninges. And as I said, I'll show you a picture in the next couple of slides. So remember that. Just remember that phrase when it comes to a Brzezinski sign. So what are our overall kind of symptoms and signs then associated with meningitis? Well, we've got this concept of meningism, so headache, photophobia, neck stiffness, which I'm sure you all know about, fever, nausea, vomiting, and really bad cases as well, you can get seizures. So those are some really core symptoms that you need to be aware of. Now, signs, we've already talked about Brzezinski sign there, and Koenig sign is another really important one. So when the hip is flexed and the knee is at 90 degrees, extension of the knee results in pain. That will make more sense on the next slide. But those are the two big signs I want you to remember. Eponymous signs anyway. We've got this rash we talked about, the purpuric non-blanching rash, which is seen in meningococcal disease, which is caused by Neisseria meningitidis, and obviously pyrexia and potentially reduced GCS as well. So what are these two signs that I keep going on about? Well, we've got one on the left there. So on the left, you've got Koenig sign. So when the hip is flexed and the knee is at 90 degrees, as you can see there, extension of the knee, which is what this doctor is doing here, results in pain. And this image on the right is demonstrating Brzezinski sign, where you, as the clinician, are passively flexing the patient's neck. And this, this meningeal irritation causes the hips to flex and the knees to flex when this neck is being passively flexed. And that's all these two signs are. And two really important ones to remember when it comes to meningitis. I was also talking about that non-blanching rash earlier, the purpuric rash. So this image on the left demonstrates a really severe example of that in a young child. There's non-blanching rash. And this is a classic example of meningococcal septicemia and the potential devastating complications of the condition. As you can see there on the right, patients that become profoundly septic, you go into a really significant prothrombotic state as well, disseminated intravascular coagulation. and develop really, really, really severe complications of the condition. And this is why we think about meningitis as such an important diagnosis that we simply cannot miss. So in terms of differentiating between a few of these, so we've got viral, bacterial, tuberculous, and also encephalitis. Here are a few ways we can do it symptom-wise. So we've got viral and bacterial meningitis. They're usually acute onset. They demonstrate meningism, like we talked about. Viral is usually self-limiting to a degree, whereas bacterial is really severe. Patients are really unwell. They can become septic very quickly, and it may be fatal. Viral meningitis can be fatal, but the rates of fatality are significantly lower with viral compared to bacterial. And I will touch on CSF interpretation in a moment. Tuberculous meningitis is usually kind of more of a chronic course, and often kind of have these prodromal symptoms of kind of fatigue and malaise and fever before kind of those more characteristic meningitic symptoms. Now, CSF interpretation is really important, but also you want to do some blood tests and get some cultures sent off. So PCR, polymerase chain reaction, and Zeal-Nielsen staining is really important, and obviously a chest X-ray to look for active pulmonary tuberculosis as well. Encephalitis we'll talk about soon, but is and you know characteristically is more associated with and encephalitis just refers to inflammation of the brain parenchyma or brain tissue rather than just the meninges, and this characteristically causes kind of changes in personality, maybe psychotic behaviors, and basically changes in your cerebral function, but you may have some features of meningism there as well. So we've already touched on investigations there to agree, but let's go into a little bit more depth. So they're going to separate it. So first of all, as we always do, bedside and bloods first of all. So we need to do a blood glucose. And for that, the main reason we're doing this is because we need a blood glucose because we're going to be comparing that to the glucose in the cerebrospinal fluid when we do our lumbar puncture. We need a full blood count. That's probably going to demonstrate leukocytosis or raised white blood cells. CRP will demonstrate raised inflammatory markers. We want to get a coagulation profile. Patients, as they become more unwell, they can get septic and demonstrate something called disseminated intravascular coagulation, which is a really severe complication of nasty infections, where patients are at increased risk of bleeding and at increased risk of clotting, and it's quite a difficult condition to manage. We're going to be doing blood cultures, and then we can do PCR for Neisseria meningitis as well. So those are a few bedside and blood tests as well. Imaging, we're probably going to end up doing a CT head. It may demonstrate what we call meningeal enhancement. And, you know, it's not going to be diagnostic of meningitis by any means, but it usually is conducted prior to a lumbar puncture in patients that present with these strange neurological symptoms, particularly to rule out anything else intracranial that we may have missed. That is separate to meningitis. And then special tests, lumbar puncture, which I'm going to be touching on just now. So microscopy and culture and PCR as well. Lumbar puncture, I'm sure we all know, so it's generally performed at that kind of L3, L4 interspace or below. Not a particularly comfortable procedure for patients. And we take a sample of cerebrospinal fluid or samples and measure opening pressures and things like that. But we need to know how we're going to interpret these CSF results now. And this is really the table that you need to remember. It's straight from our textbook. There are different, different resources give different cutoffs. These, the precise cutoffs are not set in stone by any means, but we can generally kind of separate this into bacterial, viral, and then kind of fungal TB. And we want to kind of look at pressures. So if we focus on bacterial first, bacterial, the opening pressure. So literally when you do your lumbar puncture, you're going to measure the pressures that are produced during that process. So that is going to be elevated in bacterial. The appearance of the CSF is going to be quite cloudy. You're going to have significantly raised white cells within your cerebrospinal fluid. The main cells you're going to see are known as polymorphonuclear neutrophils, or PMNs. And because you've got bacteria in your cerebrospinal fluid, all that bacteria are eating up all the sugar in your cerebrospinal fluid, and therefore your glucose is going to be in your CSF is going to be less than 50% of the glucose in your blood. And that is why we're checking glucose in our blood. And that is why in bacterial meningitis, it's going to be less than 50%. And your protein is going to be elevated in your CSF. And that's bacterial. Now, the main things that are different here with viral, and like I said, always comes up in exams and really important to know in clinical practice as well. Pressures can be normal, but are often elevated. Appearance is clear, not cloudy. White cells are often less than 1,000. Instead of PMNs, we've actually got lymphocytes being predominant in general, and glucose is actually usually more than 60% compared to your serum. And that's because you haven't got any bacteria eating up all of your glucose. Protein is usually less than 1. And then fungal, the main differences here are going to be particularly cloudy here compared to viral, and TB. Once again, more from an exam point of view, is often described its appearance as a fibrin web. And that's usually what you'd see in TB. And then these other bits here, so have a look at the white cells, lymphocytes, glucose. And as you can see here, the glucose is going to be usually less than 50%, much like in bacterial when you have fungal or TB. So hopefully that makes sense to everyone. How do you measure CSF pressure? So literally you put the needle in, and the first thing you do when you're doing a lumbar puncture usually is you're going to attach the pressure gauge, and that's literally the CSF will rise up that the gauge, and it will show the millimeters of mercury or the pressure that's being produced. And if it's significantly elevated, we're thinking there's some pathophysiological process going on. If you simply Google, I should have probably put a picture of it. If you Google it, you'll see exactly what I'm talking about. So management of meningitis, then, relatively straightforward. So if we split it up into primary care, secondary care. So in primary care, and these are empirical management options. So this is what I mean by empirical, is this is before we've done cultures and got our sensitivities and things. This is like you see a patient, you think you've got meningitis, and we need to treat it. So in primary care, we give IV or IM benzyl penicillin if there is evidence of a non-blanching rash. So this is a stat or one-off dose in the community if you're suspecting meningococcal infection, i.e. you've got a rash or septicemia. That's exactly what NICE says. IV is actually preferred to IM according to NICE, but really either will do, and then you need to get them to hospital straight away. If giving those antibiotics is going to delay transfer to hospital, do not give them. The priority is to get them to hospital according to NICE, and obviously that makes complete sense. If they're in hospital and you're suspecting meningitis, but obviously you haven't got cultures, etc. back, we're giving an IV cephalosporin, so for example, cefotaxime, and plus or minus amoxicillin. And that amoxicillin is to cover listeria. So if you remember, listeria affects people who are very young usually and people who are very old. So if you're less than 3 months, we're going to add on amoxicillin. And if you're more than 50 years old, we're going to add on amoxicillin. And that is to protect you from, or to cover you against listeria. Whereas the cephalosporin here is going to cover against Neisseria, pneumococcus, and others as well. So hopefully that makes sense to everyone. We give steroids. So ideally, we're going to give some steroids, so dexamethasone, before or at the same time as your antibiotics. It reduces your mortality, and it reduces the likelihood of really significant neurological complications. But it must be given within 12 hours of your antibiotics, according to NICE. If you're thinking there's a viral meningitis, that could be a possibility, then we can give acyclovir and cover for that as well. And then adjuncts are obviously, IV fluids, analgesia, antiemetics, paracetamol, all of those types of things. But that's a really basic management of meningitis. Now, meningitis is a notifiable disease. So there is a whole process, according to Public Health England, of contact tracing. So let's think about meningococcal meningitis, first of all. So we need to contact trace anyone who has had prolonged close contact in a household setting in the preceding 7 days before the illness. We all know lots about contact tracing now because of COVID, but the main two reasons that we need to contact trace, so imagine you've got a patient you've seen in A&E and they've been admitted with meningococcal meningitis, you then need to contact trace if they meet this first bullet point or this second bullet point. And the second bullet point is anyone who's had exposure to respiratory droplets from that patient, regardless of the closeness of that contact. You then find these people. You can then give, usually give ciprofloxacin 500 mg as a one-off dose to anyone who meets either of these criteria. And rifampicin would be an alternative as well. So that's meningococcal contact tracing. And then pneumococcal meningitis, usually prophylaxis isn't required. So there are a few basic bits about contact tracing there. They can be a little bit more complicated, so I'm not going to go into too much more detail about that because that's really all you need to know. So that was a whistle-stop tour of meningitis. We're going to head on to the next condition now, but just remember really that, there are lots of complications associated with meningitis. Neurological are obviously the one that we need to worry about most, but obviously sepsis as a general systemic complication is so important. You saw that picture of that child and the complications that can occur with sepsis. So take a look at these neurological ones, like hearing loss, seizures, long-term cognitive and behavioral deficits, etc. We've got one endocrine condition here. This is called Waterhouse-Friderichsen syndrome. It's adrenal gland failure due to bleeding into your adrenal gland, which is what's shown here. And essentially it's hemorrhagic necrosis. So it's due to severe meningococcal infection. That is the most common cause. So Neisseria meningitidis, severe meningococcal infection can actually cause adrenal gland failure. And that is known as Waterhouse-Friderichsen syndrome. I'm just going to check, see how we're doing for time. Okay. So that was a lot. We've covered a lot. Does anyone have any questions before we move on to the next condition? DIC does cause bleeding. It causes a prothrombotic state and increases your risk of bleeding at the same time because it uses up all of your coagulation factors. So it causes both, and that's why it's often so difficult to manage. So case-based discussion number 3. So we have a 34-year-old male who's reported to his wife that he has a generalized headache. His wife notices that he looks distractible and confused. His wife reassures him that he should feel better soon, but later in the evening, he's found shaking vigorously in his bed, and his wife calls the ambulance, and thankfully this shaking stops. There are his observations, and as you can hopefully tell, tachycardic and pyrexic as well. So not looking good. As you can see, he's been shaking, he's got this headache, he looks confused, and he's got a fever. So we are worried about him. We've kind of almost touched on this already, so hopefully you've been listening. What is the most likely causative organism in this case? Have a think. All right, let's see what you think. Brilliant. You either knew it already or you've been listening. Either way, very well done, very proud. And if you've been listening, even better. So it's good to see. Wonderful. Thank you. Yes. So HSV1 is responsible, herpes simplex virus 1 is responsible for 95% of cases of encephalitis. Herpes simplex virus 2 is a key cause of viral meningitis. How I remember this, and it doesn't make much logical sense really, meningitis has 2 N's in it, and therefore herpes simplex virus 2. That's how I remember it, whereas HSV1 is therefore encephalitis. All right, so let's talk a little bit more about encephalitis. So why do we think it's encephalitis and what is it? Well, encephalitis just refers to inflammation of your brain parenchyma, as I touched on before. It often causes headache, changes in your personality, can cause confusion, and it can cause seizures, as you can see here with this pyrexia. So we've touched on what encephalitis is, and the key risk factor overall is going to be immunocompromised. So extremes of age, HIV, chemotherapy, etc., all those ones that we talked about before. But lots of causes of encephalitis have kind of more specific risk factors. And I'm not going to touch on every single one here, but if we think about virals, so we've got HSV1. I'm sure you all know, HSV1 is particularly oral-to-oral contact, kissing, etc. You get, herpes. When you get herpes, you get mouth ulcers, etc. HSV2 is more in terms of sex, and you can get genital ulcers. So that's HSV1, HSV2 risk factors. Now, other key ones I want you to focus on are going to be things that are a little bit more rogue. So, things like Japanese encephalitis virus, West Nile virus, we're thinking about mosquito bites, for example. A bit weird and wonderful. CMV and EBV, so cytomegalovirus, Epstein-Barr virus, particularly things like transfusion and transplantation. So this is more kind of a table that you should look back in your own time and make sure you understand these specific risk factors. We're thinking about bacterial. We've talked more about kind of Neisseria meningitidis and the prolonged contact, how that's a risk factor. TB, I'm sure we all know, once again, close contact, coming from endemic areas, and syphilis is also a key cause, unprotected sexual activity. You can get syphilis as a cause of your encephalitis as well. Fungal is predominantly Cryptococcus, and that's associated with transplantation, as well organ transplantation. And this is the big one, which always everyone seems to remember and comes up in exams, Toxoplasmosis, close contact with cats, and I'll talk a little bit more about that later on, because it's a little bit rogue once again, and one that people just seem to remember, and it does come up in exams sometimes as well. I'm not saying that everyone with cats needs to then go and sell their cat. Not at all. This is more of something that is it's a link that has been recognized. Okay, so symptoms, signs. We've touched on this already quite a bit. So fever, headache, and those behavioral changes are key symptoms to remember. And changes in personality also come under that umbrella as well. Like in this case, patients can be confused and they can even develop seizures as well. Signs, check their temperature. They're often going to have a raised temperature, may have a reduced GCS or kind of fluctuating level of consciousness, and they may even develop focal neurological deficits, so aphasia, weakness on one side of the body, for example, and even cerebellar signs as well. So those are your key symptoms and signs of encephalitis. We want to swab the throat, see if there's any viral pathogens, organisms that we can pick up in the throat as well. HIV serology is really important and are routinely tested in essentially all emergency departments in the UK. Now, those patients kind of routinely will get a CT or MRI ahead. CT is going to be normal in quite a significant number of cases, and that's why MRI is preferred. And particularly, characteristically will often show inflammation in the medial temporal and inferior frontal lobes, HSV encephalitis. You don't necessarily need to remember that. Like we were saying, MRI is preferred. But of course, we're going to need to do a lumbar puncture on these patients. So usually these patients will be seen in A&E, given some empirical management, come under medics, and then they'll have their lumbar puncture. Lumbar puncture usually shows lymphocytosis, so raised white blood cells and raised protein. Like we talked about, this is a viral etiology, and these are the similar things that we would expect in viral meningitis as well. PCR, we're going to be doing assays for your common viral infections, and particularly including HSV as the most common cause of encephalitis. Culture, in case there's a bacterial underlying cause. And then we can also do serology for specific viral antigens as well. But I wouldn't get too bogged down in that right now. But yes, those are the key investigations that we're going to do. And obviously there's one that we can consider, which is EEG, relatively non-specific, but the key thing that always comes up in exams is this periodic lateralized discharges at 2 Hertz. I am not an expert at EEGs. I would not even be able to tell you necessarily what that looks like on an EEG, but that is a key thing that comes up in exams. But as I said, it's non-specific. All right, how do we manage these patients then? Well, as we know, this is a viral, like 95% of cases are caused by virus, HSV. So we're going to be treating with antivirals. Acyclovir is basically commenced empirically in all patients with suspected encephalitis, because it will cover for the most common cause, which is HSV. Ganciclovir may be preferred if we're thinking about other herpes virus infections like HHV6. Now, you may not have heard of herpes virus infections, and that's why I'm going to test you a little bit on them on the next slide. And then another one combination is going to be ganciclovir with foscarnet, and this is usually used in cytomegalovirus encephalitis. And these are really from kind of a, the precise guidelines will vary place to place. So I wouldn't get too worried about exactly what antivirals you use, but these are the key ones that come up in exams all the time and are often used across trusts around the UK. But obviously further management will depend on your underlying organisms. So we touched on herpes virus infections here, and it would be rude of me not to go into a little bit more depth on what we're talking about when we talk about human herpes viruses. So let's touch on this, but this is really something you should try and go into more detail in your own time. So, which of the following herpes viruses is associated with Kaposi's sarcoma? Now, Kaposi's sarcoma is not a neurological condition, but this human herpes virus is important to understand its association with Kaposi's sarcoma. And as I said, HSV is the most common cause of encephalitis, which falls under the umbrella of your human herpes viruses. So I just thought we'd have a bit more of an in-depth think about these HHVs. So let's see what you think. Oh, well done. Brilliant. Okay, so 60% of you have said HHV8 or human herpes virus 8, and you'd be absolutely correct. It's associated with this condition called Kaposi's sarcoma associated. All right, let's do this again. Oh, come on. Okay, so which of the following herpes viruses is associated with Kaposi's sarcoma? Now, Kaposi's sarcoma is not a neurological condition, but it is strongly associated with one of these human herpes viruses, which is important to have a think about if we're thinking about encephalitis as a whole, because obviously the most common cause is herpes simplex virus. So which of the following is associated with Kaposi's sarcoma? And what do you think? Oh, brill. Okay, so 60% of you said HHV8, and you would be absolutely correct. Well done. So yes, HHV is known as Kaposi's sarcoma associated herpes virus because it's strongly associated with Kaposi's sarcoma. Now, these human herpes viruses are really important to remember both through your exams and for clinical practice. So I'd recommend reading these in your own time and having an understanding of the subfamilies. So we've got alpha, beta, and the gamma herpes viridae, and then thinking about the species. So 1, 2, 3, all the way up to 8, and then the common names. And then thinking in more depth, HSV1, HSV2, VZV, CMV, etc. What are the risk factors for these particular viruses, and how do we treat them? Always comes up in exams, so really important to remember. But do take a look at that in your own time. Acid antagonist, and this is your treatment of choice for toxoplasmosis. And why do we think it is Toxoplasmosis, cerebral toxoplasmosis. Well, we've already talked about the seizure, got track marks, which suggests intravenous drug use, probably as the underlying cause of his HIV, unmanaged HIV. So we have no idea what his viral load is. He's probably significantly immunocompromised and has now developed these ring-enhancing lesions, which are cerebral toxoplasmosis. Final case of the day. We now have a 32-year-old female who presents to the emergency department with weakness, which started in her legs, but is now affecting her arms and hands. This is also associated with numbness and tingling, and the patient also describes a 5-day episode of diarrhea around 4 weeks ago. A bit of an odd history, but that's what she tells you when you're assessing her in A&E, and it's all a little bit odd. But here's our last question. Based on that bit strange history, what is the most likely underlying cause of this patient's presentation? What is the most likely underlying cause? Last question of the day, last case of the day. What do we think? I like to think this is slightly trickier, but you've all proven me wrong and got basically all of them right. No, there we go. Brill. Campylobacter jejuni or jejuni. Spot on. So this is an unusual condition. The condition itself is not an infective disease, but the most common cause of this condition is infection. And the condition is called Guillain-Barré Syndrome. And Campylobacter jejuni is the most common cause of Guillain-Barré Syndrome. And let's touch a little bit more on this condition then. So Guillain-Barré is this autoimmune, rapidly progressive, demyelinating condition of the peripheral nervous system. So usually there's an infection, most commonly Campylobacter, which essentially causes, food poisoning, gastroenteritis type symptoms, which is what the diarrhea was here. And then essentially this process called molecular mimicry is what we think causes these strange neurological symptoms. So basically this pathogenic antigen, which is the Campylobacter, resembles myelin gangliosides in the peripheral nervous system. The immune system targets the antigen, attacks the myelin sheath and the motor nerves, and then this whole autoimmune process involves these antibodies called anti-ganglioside antibodies. And this whole process is known as molecular mimicry. How do patients present? Well, they present, like in this case, with ascending weakness, i.e. weakness which starts in the legs and then moves up towards the arms. It's symmetrical in nature, and usually patients present with kind of, you have to really tease it out of these patients, but some history of infection, for example, this diarrhea in the previous 6 weeks. They may have some other neurological symptoms like tingling and numbness with lower motor neuron signs, so your hyperreflexia, etc., hyporeflexia, that is, ataxia. In really significant cases, they may even go into respiratory distress and get really, really unwell and end up in ITU. So it can be a really significant and severe condition. And it's often missed because the symptoms are a little bit strange. So how do we investigate and manage it? Well, the guidelines suggest that it's predominantly a clinical diagnosis. So if you have this combination of features, so progressive weakness with areflexia or hyperreflexia in these weak limbs, that is, you can be quite, not necessarily confident of your diagnosis, but it's highly suggestive of Guillain-Barré. But you need to investigate to exclude all your other causes as well. So you're going to do your full set of bloods, you're going to do CT scans, etc., MRI, to rule out other causes. Some investigations as well, so anti-ganglioside antibodies, which are the antibodies involved in this process, are found in around 25% of patients, and not all of them. We're going to do cultures, lumbar puncture, MRI, and once again, particularly to rule out some of those other causes as well. A lumbar puncture, raised protein and normal white cells is quite typical of Guillain-Barré, but an initial kind of normal protein level doesn't necessarily exclude the condition. And our management is IV immunoglobulins or plasma exchange. Immunoglobulins are literally IV antibodies or plasma exchange. Are your two main treatments. If you want more detail, just check out our textbook and you'll learn more about Guillain-Barré. And why do we think it's a condition in this case? Well, we've got this ascending weakness, we've got these numbness and tingling, and this evidence of possible Campylobacter infection 4 weeks ago. So this patient will present. We can do cultures if they've still got any ongoing symptoms. You would culture stool, for example, but obviously these symptoms were quite a while ago, so there's probably nothing to culture now. Wow, so we covered a huge amount and we are done. So we've talked about meningitis, encephalitis, we touched on our human herpes viruses, we talked about cerebral toxoplasmosis / cerebral abscess, and we talked about Guillain-Barré. So lots of things to digest and think about. I'm really sorry about those technical issues. I have no idea why they occurred because my Wi-Fi looks pretty good. So please forgive me for those. Hopefully you still managed to follow all the way through to the end. And I hope you enjoyed it. If you want to learn more about really, I think if any of these conditions we now have in the textbook, maybe other than cerebral toxoplasmosis, simply check out our question bank and textbook to learn more about all of these conditions. They're all available there. And as I said, you can use my discount code Azim2021 for a further discount. Please do leave some feedback if you can. I'd really appreciate it. Obviously, feel free to mention the technical issues, but I'm very aware of them and I'll get them, make sure it doesn't happen again. And everyone, thank you so much for attending, so many of you, and have a really wonderful evening or day depending on where you are in the world, and I'll take any questions if you do have any. Feel free to pop them in the chat or the Q&A if you do have any questions. I'll stick around for a minute or so.